Good morning, everyone. My name is Dr.Melanie. I'm Senior Resident of the Department of Orthopedics, Sri Lakshmi Narayan Institute of Medical Sciences, Puducherry. And today I'll be talking about deep vein thrombosis. Deep vein thrombosis is a major cause of morbidity and mortality in hospitalized patients. One in 30 to 40 patients who are operated on for hip fractures or joint replacements develop a symptomatic thromboembolic complication despite the use of prophylaxis during the hospital stay. Most frequently, it develops in the calf veins and less often in the proximal veins of the thigh and pelvis. Coming to the cause and pathophysiology. As we all know, there's a virtuous triad which results in DVT. One is which are stasis of blood flow, hypercoagulability, and endothelial injury. First, coming to stasis of blood flow, labeled fibrinogen studies in patients as well as in autopsy studies have demonstrated convincingly that the soleal sinuses are the most common sites of initiation of venous thrombosis. The stasis may contribute to the endothelial cellular layer contacting activated platelets and procoagulant factors, thereby leading to DVT. Stasis in itself has never been shown to be a causative factor. Hypercoagulable state. After major surgery, large amounts of tissue factors may be released into the bloodstream from damaged tissues. Tissue factor is a potent procoagulant expressed on the leukocyte cell surface as well as in a soluble form in the bloodstream. Increases in platelet count, adhesiveness, changes in coagulation cascade, and endogenous fibrinolytic activity result from physiological stress, which in turn is associated with an increased risk for thrombosis. Finally, endothelial injury. Blood flow in the veins may be obstructed by the torsion, like that needed to expose the femoral canal and the acetabulum in hip replacements. This damages the endothelium, both in the proximal femoral vein by torsion and in the distal veins by distension. What are the increased risks of thrombosis? One, elderly patients more than 65 years, in case of malignant diseases, increased BMI, pregnancy, prolonged immobilization, and tobacco use. Coming to the clinical features, thromboembolic events can be presented as a pyramid, where majority of the cases, the base of the pyramid, there's no DVT. Then comes the asymptomatic DVT, symptomatic DVT, symptomatic pulmonary embolism, and finally the tip of the iceberg, which is your fatal pulmonary embolism. DVT is usually asymptomatic, although some patients present with pain in the calf or thigh. A sudden slight increase in temperature and pulse rate may develop. There are usually no signs, but there may be calf swelling and tenderness. Gomes test, which is increased pain on passive dorsiflexion of the foot, although still frequently employed, is now regarded as unreliable. What is the signs of pulmonary embolism? Patients may develop pleuritic pain in the chest and shortness of breath. In most cases, pulmonary embolism is completely asymptomatic. Fatal pulmonary embolism usually presents as a sudden collapse without prior symptoms in the legs or chest. Now, how will we diagnose DVT? There are various imaging studies and laboratory tests. These include venography, impedance plethysmography, fibrin and fibrinogen assays, duplex ultrasound, which is the current test of choice, and magnetic resonance venous imaging. Venography. What is done here? The injection of contrast material has always long been considered the most accurate method of confirming DVT, and its location. Superficial venous system is occluded by tourniquet at the veins in the foot are injected for visualization. The disadvantages of this is that it is invasive and subject to risks of IV administration of contrast material. Impedance plethysmography. It measures the change in venous capacitance and the rate of emptying of the venous volume on temporary occlusion and release of occlusion of venous system. The cuff is inflated around the upper thigh until the electrical signal has plateaued. When the cuff is deflated, there is usually rapid outflow and reduction of volume. With the venous thrombosis, there's prolongation of the outflow wave. The disadvantage with this is it's not useful clinically for the detection in patients with prior venous thrombosis. Fibrin and fibrinogen assays. Fibrin and fibrinogen levels can be determined by measuring the degradation of intravascular fibrin. So D-dimer test, which measures the cross-linked degradation products, which is a surrogate of plasmin's activity on fibrin. Sensitivity in combination with clinical evaluation is 90 to 95%. Post-operatively, D-dimer is casually elevated, hence a positive result is not useful. However, a negative D-dimer test result in patients with suspected DVT has a high negative predictive value of 97 to 99%. Duplex ultrasound, which is the current test of choice. It combines Doppler ultrasound and color flow imaging. The advantage of this is that it is non-invasive, comprehensive, and without risk of reaction to contrast angiography. However, the drawback with this is it is highly operator dependent. The principle of Doppler ultrasound is impairment of an accelerated flow signal caused by an intraluminal thrombus. Evaluation of flow with distal compression, which results in augmentation of flow, and with proximal compression, which should interrupt the flow. Venous thrombosis suspected when there is failure of augmentation of the flow on distal compression. Real-time beam mode ultrasonography with color flow imaging has improved sensitivity and specificity. With color flow imaging, blood flow can be imaged in the presence of partially occluding thrombus. Probe used to compress the vein. In the presence of a thrombus, there is resistance to compression. Chronicity can also be evaluated here, depending on the echogenicity and heterogeneity of the thrombus. Coming to magnetic resonance venous imaging, this has come to the forefront from proximal venous disease itself. Its use is limited due to the cost and patient tolerance. That is, patient may have claustrophobia. It's less invasive than the conventional venography. Coming to the prevention, the overall risk, how would we prevent DVT or pulmonary embolism? The overall risk of DVT and pulmonary embolism can be reduced by prophylaxis. These include general measures, physical measures, and pharmacological measures. Coming to general measures, first we have the neuraxial anesthesia. This is spinal or epidural anesthesia reduces mortality, enhances perioperative analgesia, and reduces the risk of VTE, that's venous thromboembolism, by about 50% through enhancing blood flow. It is wise to avoid giving neuraxial anesthesia and chemical prophylaxis too close together to avoid a spinal hematoma. Better surgical technique. Rough surgical technique will potentiate thromboplastin release. Prolonged torsion of a major vein when maintaining a dislocated hip for purposes of replacement or during aggressive dorsal retraction of the tibia during knee replacement inhibits venous return and damages the endothelium. Use of a tourniquet. A tourniquet probably does not change the risk. Clotting factors that accumulate Once the tourniquet is inflated, are flushed out by the hyperemia on tourniquet deflation. And finally, early immobilization. This is a simple physiological means of improving venous flow. Now, we have some physical methods also to prevent or reduce the risk of pulmonary embolism. One is graduated compression stockings, which can halve the incidence of DVT when compared to no prophylaxis. However, the stocking should be properly worn and well fitted. Only then can it help in prevention of DVT. Intermittent plantar venous compression. This takes advantage of the fact that blood from the sole of the foot is normally expressed during weight bearing by intermittent pressure on the venous plexus around the lateral plantar arteries. This in turn increases venous blood flow in the leg. A mechanical foot pump can reproduce this physiological mechanism in patients who are confined to bed. It should not be used in combination with compression stockings, as these impair refill of the venous plexus after emptying by the foot pump. Another option is intermittent pneumatic compression of the leg. This has also been shown to reduce the risk of radiological DVT after hip replacements and in trauma. It is, however, impractical for patients undergoing operations at or below the knee. And finally, we have something called inferior vena cava filters. These resemble an umbrella and are percutaneously passed through the femoral vein and lodged in the inferior vena cava. They merely catch an embolus to prevent it from reaching the lungs. So they do not have any role in preventing DVT, but they definitely do have a role in preventing fatal pulmonary embolism. They have a specific role in the occasional case where the risk of embolism is high, yet anticoagulation is contraindicated. Example, in a patient with a pelvic fracture who has already developed a DVT but needs a major surgical reconstruction. The complication rate, which includes death from proximal coagulation, should restrict use of these devices. Next, coming to pharmaceutical methods. These are generally safe, effective, easy to administer in the form of a tablet or injection, and can be used for extended periods. They are relatively inexpensive compared with the overall cost of surgery. However, all chemical methods incur a risk of bleeding, which is a natural concern for both the orthopedic surgeon and the anesthetist. First option is the aspirin. While some authorities still recommend the use of aspirin, others advise against its use because of its relatively poor efficacy, the risk of bleeding, and the tendency to cause gastrointestinal irritation. Unfractioned heparin. This carries a risk of increased bleeding after operation and is contraindicated in elderly people. Low molecular weight heparin. This class of drug has hematological and pharmacokinetic advantages over unfractionated heparin, including ready bioavailability and a wide window of safety. Hence, monitoring is not required. Randomized studies have shown that it effectively reduces the prevalence of venographic DVT in hip and knee replacement surgery, and the effect may be amplified when coupled with physical methods. Pentasaccharides. This synthetic injectable antithrombotic drug, commonly used one is fondaparinux, precisely inhibits activated factor 10. It is at least as effective as low molecular weight heparin, but must not be given too close to surgery. It is best given 6 to 8 hours after surgery, or else bleeding may become a significant problem. The drug is excreted by the kidneys rather than metabolized with the liver, and so must be used carefully or be avoided in those with poor renal function. Direct anti-10A inhibitors and direct thrombin inhibitors. These drugs are likely to transform thromboprophylaxis. They are given orally and have a blood therapeutic and safety window, so they do not require monitoring. They are given after surgery and should be continued for as long as the patient is at risk of uh, thromboembolism. They provide a pragmatic solution for after hospital prophylaxis, requiring neither injections nor complex monitoring. The drug activity, however, is difficult to reverse. Presently, there are two available in market. Dabigatran is the direct thrombin inhibitor, and rivaroxaban is the anti-10A inhibitor. Warfarin. Warfarin has been used widely, particularly in North America. Drawbacks are difficulty in establishing appropriate dosage levels and the need for constant monitoring. If it is used at all, it must be maintained at a INR, that's International Normalized Ratio level of 2 to 3. Now, the American Academy of Orthopedic Surgeons, 2007, they came up with uh, guidelines for clinical practice guidelines for deep vein thrombosis prophylaxis. In this, we see that if the risk is, there is standard risk of pulmonary embolism and major bleeding, we can use aspirin or low molecular weight heparin, pentasaccharide, or warfarin as long as the INR is kept less than 2, less than or equal to 2. In the case of elevated risk of pulmonary embolism, standard risk of bleeding, in this case, we can use low molecular weight heparin, pentasaccharide, or warfarin. If there is standard risk of pulmonary embolism and elevated risk of bleeding, then we can use aspirin or warfarin or no prophylaxis. In the case of elevated risk of pulmonary embolism and bleeding, we can use aspirin, warfarin, or no prophylaxis. Now, when do we give the prophylaxis and for how long? In general, prophylaxis, it is given on admission to hospital, those with hip or major long bone fractures of the lower limb, particularly if the surgery is delayed beyond 24 hours. Chemical prophylaxis should not be given too close to surgery, otherwise there is a risk of provoking a bleeding complication. If it is given too long before surgery, metabolism or excretion may reduce its potency. If given too long after after surgery, metabolism or excretion may reduce its potency. If given too long after surgery, the thrombogenic process will be established and the drug is now therapeutic instead of prophylactic. Thromboprophylaxis should be prolonged for some time after discharge from the hospital. Current evidence supports 14 days of prophylaxis to be given for knee replacement and 4 to 5 weeks of prophylaxis to be given for hip replacement and hip fracture. The use of low molecular weight heparin or warfarin for 10 to 14 days post-operatively. Low-risk patients, entry-coated aspirin for another 4 weeks. High-risk patients maintained on warfarin for 4 to 6 weeks post-operatively. In 2003, the American Society of Anesthesiologists made further recommendations regarding epidural anesthesia and anticoagulation, and these guidelines were updated in 2010. These are: 1, the initiation of low molecular weight heparin should be delayed 24 hours after the procedure if blood is noted during either needle or catheter placement. Twice daily low molecular weight heparin administration is associated with increased risk of spinal hematoma. The initial dose can be administered 24 hours post-operatively if adequate hemostasis has occurred. If continuous post-operative epidural technique is used, indwelling catheters should be removed 2 hours before the first dose of low molecular weight heparin. In case of single-dose low molecular weight heparin, administration may be initiated at 6 to 8 hours post-operatively. The second dose should occur more than 24 hours after the first dose. Indwelling catheter should be removed 10 to 12 hours after the most recent dose of low molecular weight heparin. Low molecular weight heparin should not be resumed within 2 hours of catheter removal. For warfarin prophylaxis, the epidural catheter should be removed when the INR is less than 1.5. Neurological assessments should continue for 24 hours after catheter removal. If a preoperative dose of warfarin is given, the INR should be checked before epidural catheter insertion. If the first dose occurred more than 24 hours previously, or if a second anticoagulant dose has been given. What is multimodal prophylaxis? It's a combination of physical and chemical prophylaxis is needed. For patients at particularly high risk of bleeding, mechanical methods should be used until the bleeding has resolved and then can be shifted to pharmaceutical methods. In the case of established DVT, how do we proceed? Heparinization with a low molecular weight heparin and then conversion to warfarin for 3 to 6 months and surgical intervention. When is surgical intervention indicated? When the anticoagulant therapy is ineffective. It is, however, unsafe. There are two options: thrombectomy, where the thrombus is removed in its entirety, or inferior vena cava filters, which catch the insertion, it's inserted into the inferior vena cava, which then catches any embolus which may be dislodged from the extremities. Filters for DVT. The indications for this is if there is a contraindication to anticoagulants, if there is significant bleeding complication of anticoagulation therapy, pulmonary embolism with contraindication to anticoagulation therapy, and in the case of recurrent thromboembolic complications despite adequate anticoagulation therapy. So you can see here, this is the filter being placed, the direction of blood flow, and the filter catches the blood clots. The inferior vena cava filters reduce the rate of pulmonary embolism but have no effect on the other complications of DVT. Thrombolysis can be considered in patients with major proximal vein thrombosis and threatened venous infarction. Thank you.